let's come together. As you know, this time of year we have our chief residents present at Grand Rounds, and I'm proud to say we've had really a wonderful time with Dr. Perry as our cardiac fellow for the last 2 years. Has really done an outstanding job in a difficult service and really brought a whole new level of quality to our M&M presentations, which I think has trickled down and been an influence for the rest of the department and the rest of the residents. And I just really want to personally and publicly thank you for that degree of professionalism that you've really demonstrated the entire time here. It's really been a privilege to have you. It's not a secret that we're trying to figure out a way to keep you here. And we look forward today to your presentation, looking at a review of sort of where we are with cardiac surgery and mechanical circulatory support. So thank you.
Okay, good morning, everybody. We're going to talk about mechanical circulatory support. This is, of course, a huge topic, so we could go on for hours and hours and give an hour-long topic or talk on each subtopic, but try to kind of create an overview here and kind of hit what I think are a lot of the highlights now. So we're talking a little bit about epidemiology, enhance familiarity with the modern devices, so kind of raise awareness of what's out there and what they're being used for and how they fit into our current system. And then just show some of the data that exists on this. I think this is the first time probably ever that we really have some substantial data on this thing, on these devices and how they're affecting patients in healthcare, because they're actually very new. This is technology that's really only been implemented in the last probably 10 or 15 years on a more than very small scale. And then we'll talk a little bit about the future of the field and kind of some of the things we can look forward to and that are happening now and happening in the near future and in the distant future. And then kind of conclude with our experience here with mechanical circulatory support, especially in relation to durable support and LVAD therapy. Of course, have no financial disclosures. So just before I begin, I'd like to acknowledge a few people that have helped me with this talk and throughout my course here, especially Dr. Atkins, who's our head of ventricular assist device placement and mechanical circulatory support right now, and all of his influence and mentoring for me and really encouraged me to go into the field, as well as Dr. Young and Dr. Boyd, who have also contributed quite substantially to this. And the whole heart failure team here is quite important. Dr. Tong is at actually the big society meeting in France right now, so she can come. But Anka Rahman is as our VAD coordinator, and she's really instrumental to the program. And then Dr. Robert Adamson, who is actually out of Sharp Memorial in San Diego, who initially served as a proctor for us and continues to serve as a proctor for the HeartMate II, but has actually turned into quite a mentor for our program as well. Has been very important to our experience here. So I'd like to start with just a brief case summary on a patient that we were involved with for a good portion of last year, and just to kind of highlight some of the components that go into this and the way we think about these patients now. So this is a 48-year-old male who had been diagnosed for some time with non-ischemic dilated cardiomyopathy. The exact etiology was never really quite figured out. A viral myocarditis was suspected with just terrible heart failure, ejection fraction of less than 10 to 15%. A lot of rhythm disturbances, thrombus. Actually, his failure was so bad that he was forming clot in his ventricles and his atria just because he was having poor flow. He'd had biventricular pacemakers placed, AICDs. This was a guy who really hadn't, quote, done any of this to himself. He was never really involved with any substance abuse. He'd worked a job. He had 3 young children that, again, he's 48 years old. He was kind of hoping to raise and live with, and he was unable to work because of his severe heart failure symptoms. So he was kind of being followed. He's involved with heart failure cardiology. He had multiple admissions, all these procedures, but he's just continuing to get worse, deteriorate, what we call cardiac cachexia. Basically, he's being starved because he's got poor perfusion. He actually had an acute MI because of his low cardiac output, and his renal function was worsening. He had a bunch of admissions, actually 5 admissions within a 2-month period for heart failure exacerbations. And on this final admission, before we really intervened on a lot of this stuff, he was in acute renal insufficiency due to poor flow. He was requiring dialysis now. He was in liver failure, altered, IV inotropes, of course. A balloon pump was placed. They weren't able to wean any of this stuff. It was just getting worse. So there's a lot of assessment of what to do for this man. He had been evaluated, he'd been thought about for transplant, but due to insurance issues and other things, it wasn't really quite the right time, and he was having a hard time getting plugged into the system for it. So that was kind of in the back burner, but now he's here in the hospital with an acute problem, getting worse. So we finally made the decision to place a percutaneous ventricular assist device. This was a right axillary impella that we implanted. It's called a 5.0 because it can generally provide at least 5 liters of flow. So it's completely offloading. He had that device actually in place for 46 days while we were deciding what to do with him. This is a device that, when it was first approved, was for I think it's like a 6 or 12-hour window. So that's the official FDA designation for it. But people are using it for much longer periods of time, and we'll talk more about the development of that. But this worked for him. His hemodynamics were able to get better. He had some problems, a lot of GI dysfunction, pancreatitis, and cholecystitis that kind of put things on hold a little bit, but he continually got better from that. So about a month later, we took out the impella and placed a HeartMate II LVAD in him. This is a durable device that can provide ventricular support. He actually got quite a bit better with that. He came off dialysis, his renal function improved, and overall symptomatically got better. Here's a picture of him leaving the ICU right before he went to PM&R on post-op day 28, so we're all very happy to see him moving along. And then here he is seen in the clinic sometime after that. Now he's being listed for heart transplantation. So this is a good success story, and a man who, fairly young and has children and that sort of thing. So we're really happy about the outcome for this particular patient. So heart failure in general is, of course, a big topic, but in summary, it's a clinical syndrome characterized by poor systemic perfusion. So there's different types of it, systolic and diastolic. We're all aware of those, but essentially you're just not getting enough flow. And we look at that, we classify this with the NYHA classification that everybody's familiar with, and 1 through 4, and of course 1 is not too bad, and 4 is pretty severe. Or dyspnea with just at rest, you're just always feeling short of breath and terrible. And I think it's probably important for everybody in the audience to be aware of the new AHA classifications for not only heart failure but other cardiac pathology as well, where they rate it A through D. And this is a classification that's more built on the risk of somebody developing a problem. So you see Class A there is people that maybe have had a family history of cardiomyopathy, and then D being at end stage. So it kind of classifies the disease process and where they are in terms of the pathology. So D is refractory end stage heart failure, and those are people that are evaluated for transplant. 5.7 million Americans, it's a huge problem. 600 to 700,000 new diagnoses each year. In 2009, CDC said probably 1 in 9 deaths were in some way related to heart failure. There's 500,000 Americans at any given time that are in heart failure refractory to medical management. So these are people that are at the end of the road, basically people that would almost qualify for transplantation. And as you'll see, transplants only compromise about 2,500 cases a year. So this is 1 in 200 people that have end-stage heart failure. 50% of those who have heart failure will die within a few years, and the 1 and 2 year survival is just dismal when you're in NYHA 4 symptoms. Of course, it costs a lot of money, and people are getting older. So this is a cartoon I really like, actually. It's from a book on therapeutic strategies for managing heart failure. It's just all the different ways you can kind of, what you can do to the heart. So you can whip the horse, meaning, inotropes and just making it work harder, which is, of course, not a long-term durable strategy, but it does get you an immediate result. Unload the wagon, we do that a lot. That's probably the mainstay of medical therapy, diuresis, as well as slowing the horse, just kind of calming it down, making the work easier for it, but of course you're getting less mileage out of the horse. Get a new horse, that's a good therapy, transplant, but those are limited. Get a tractor, and that's kind of a lot what we're talking about today. And then heal the horse, which is something that I think hopefully in my career we'll see something of, but we're not quite there yet. So indications for heart transplant, there's a lot of pathology that can cause a heart to fail, but it's important to know that a fair amount of it isn't just coronary disease and that sort of thing, obesity related. These are just things that happen to people. Some of it's genetic, some of it's never understood, some of it's congenital, some of it's after heart surgery or somewhat iatrogenic, but there's a lot of things that cause heart failure. Absolute contraindications to having a heart transplant would include things like overwhelming infection or high pulmonary vascular resistance, where you need a lung transplant as well, or malignancy. And then there's all these relative complications. That's why I include this slide, because there's a lot of things that give people pause for doing a heart transplant, especially because there's a very limited supply of organs. So age has traditionally been a thing for a while. Age over 60 was a contraindication. A lot of people use 65 now. Some centers will use 72 as a cutoff. But I mean, my parents are that age now, and I'd like them to live a lot longer and stuff. So this is, age is an important thing here. And then severe systemic disease. So you almost get the sense they're looking for reasons not to transplant somebody, again, because it's very limited organ supply. And so things like diabetes are listed, diverticulosis, even biliary things. So all these things that really kind of limit the people that are able to get transplants. This is from the Human and Health and Human Services website, and they actually give really good data on how many people are transplanted every year and who gets transplanted and how often. And it's kind of a little cumbersome to look through the numbers, but essentially they're classified by 1A, 1B, and 2, with 1A being people that are urgently need something done, like they're in the hospital on inotropes and or mechanical support, and they're dying and they need something done right away. So a lot of those people are at the top of the list, and a lot of them get transplanted. You can see the numbers are pretty good, probably about 80%. That still means 1 in 5 people die waiting for that therapy, or could potentially die, won't get a transplant. 1B are people that are still requiring a lot of support, either with a mechanical device or even a drip at home, but they are able to be home and they're just kind of waiting for an organ, and the number's not quite as good there, but still 50, 70%, 80%, a lot of people that don't get the transplant. And then there's class 2 people. So these are people that, they're class 2 and it's not as bad as 1A or 1B, but they feel terrible, right? They're in stage D or stage 4. They're on oral medical therapy. They're having to see their doctors all the time. And those people really don't get transplanted very much. You can see, 50% every year. So this is a lot of people that aren't able to get their organs that they need. And then if you look at the data, this is just the actual transplants that are done every year. And you can see, I think what's important to note here is there's only 2,500 hearts or so done in the U.S. every year. And that number has really been static since the mid-'80s because there's only so many organs out there. You just can't create more hearts. And we're doing a lot of heart transplants. I mean, we're doing more than all of Europe combined. So we're trying, we're being aggressive, so to speak, with this therapy, but there's just very limited supply. And then if you go to that same website, it'll tell you exactly how many people are waiting for a transplant as of today. This is actually yesterday when I made my slides, but 4,000 people waiting to get one of those 2,500 hearts every year. So it's a big problem. So for people that can't have that, we look to other things that we can do, and that's what a lot of this talk is about. So mechanical circulatory support, there's lots of ways to classify it and talk about it. One thing is location. So if it's completely inside the body, outside the body combination, then what part of the heart we're working with, left, right, both the left and the right heart, even a total artificial heart. The mechanism, and we'll talk about some of the devices, but there's continuous flow and pulsatile flow. And then I think in some of the newer generation, we're getting continuous pulsatile flow because they can vary the flow with it as it's become more sophisticated. And then sort of, you classify the indication if it's a short, medium, or long term. So all these ways of kind of thinking about it. And then in terms of goals of mechanical circulatory support, we talk a lot, and this is going to be important for the talk. What's our endpoint? Why are we putting it? So bridge to transplantation and destination therapy are probably the most important things. So bridge to transplantation means we're putting in some sort of support device to get somebody through, hoping to get them a heart. Hoping to get them a heart transplant. For people that you don't think are going to survive the wait to get their organ, you're bridging them to a transplantation. And then there's this other group of patients that you just know will never be able to get a heart transplant for whatever reason. So that's destination therapy. That means this is something that's being put in them to prolong their life as long as you can and give them some sort of quality and quantity of life. And then there's all these subclassifications that are really becoming more talked about in the field right now because we're using these devices in creative ways to kind of get people to different goals based on that particular person and patient-centered outcomes. So it's a bridge to recovery. We'll talk about a patient we had that we did that for, where you wait it out with the mechanical circulatory support until they get better, trying to get some people better so that they can become a transplant candidate, and some people just while you're waiting to make a decision. Sometimes bridge to bridge, meaning putting in a short-term device and then exchanging it for a long-term. This isn't an ECMO talk, so we're not going to go into that too much, but I just wanted to put in a little disclaimer about that. And probably the biggest difference here is that ECMO is pretty much a short-term thing, and ECMO intrinsically includes oxygenation. So there's ECLS, which can be circulatory support, but if it's ECMO, it's oxygenation. And so that in those cases, you're really supporting the circulatory system and the respiratory system, whereas mechanical circulatory support refers more just to the circulatory system of people that are oxygenating just fine. Lots of differences between the two, but we're not talking about ECMO today. So indications for a mechanical circulatory support really are the same things as transplant patients, but I would add on there people that are waiting a transplant or for whatever reason can't receive a transplant. And then, what exactly does that mean with the criteria and how sick do you have to be? Well, anybody who has unacceptable hemodynamics, meaning the cardiac index is less than 2 or the wedge or right atrial pressure is really high, indicating left or right ventricular failure. Persistent hypotension despite optimal medical therapy, which is usually defined as 2 inotropes and or a balloon pump. Evidence of end organ hypoperfusion, like the patient I talked about in the beginning who's going to renal failure, altered mental status, that sort of thing. And then patients that are maybe you just know are going to have to wait a long time. The plasma reactive antibodies on some patients is very poor for transplantation, so you just know that getting an organ is going to be tough for them. Type O blood is a risk factor for not getting a transplant because it's hard to blood donor match those people, and then other things like body surface area, which is becoming more important for a lot of our patients. Contraindications, things that these all kind of make sense, but basically if there's something there that really gives you pause. But I put a question mark by advanced age because I think this is something that's being challenged. Dr. Adamson gave us some nice data from his own experience in San Diego, kind of talking about how some of his older patients, meaning those that are like 70 plus and 80 plus, have actually done quite well with mechanical support. So I think that's something that's really going to kind of evolve in the next few years in terms of people that aren't candidates for this sort of thing. We'll go into this more later, but complications associated with the device, I just want you to kind of put these in your mind and think about them as we go through the different devices and the data and stuff. But probably the main things here are bleeding, right ventricular failure. So we're supporting a lot of times the left ventricle because that's the main pumping chamber, but the right ventricle has to be protected as well. And so RV failure is a big deal. Like Dr. Atkins told me, you have to do an LVAD fellowship to learn about the right heart. So I think it's a really interesting thing. Thrombosis, embolism, infection, and then people that just kind of don't do well and have failure to thrive. So when you get somebody who's sick and not doing well, you have to kind of sort of stratify them into these different groups. And some patients you just know there's somebody who just needs real temporary support. So that could even mean somebody who's undergoing a high-risk PCI or undergoing high-risk coronary cardiac surgery. You might just want to include some temporary support for them. And then there's other patients that, like the one we talked about in the beginning, that really need something more long-term and durable. That's at the other end of the spectrum. And there's a lot of these people that are kind of in the middle where you're trying to figure out where they're going to fall, and you can use temporary support and ECMO for them. I did title the talk Past, Present, and Future of Mechanical Support, but honestly there's just not a lot of time to talk about. There's so much going on in the present and the future with it that I didn't want to dwell too much on the past, but just a little bit of historical note on this. First, I think successful use of a paracorporeal VAD or real ventricular support system was in 1966 by Dr. DeBakey at the Methodist Hospital. This was the first patient who really survived. There have been kind of a couple other things that have been done before that, but all those patients died pretty quickly. But this was a patient who had heart surgery, did poorly post-op. They put in this paracorporeal valve where basically they're bypassing the left heart with this machine, and then did that for 10 days and were able to finally discontinue it and get him home. And then in 1982, this was a big accomplishment. The Jarvik total artificial heart was implanted at the University of Utah. This was the first use of a total artificial heart system. It was in a patient who was from Seattle and kind of knew he was dying at end stage, but wanted to be a part of this, trying out this new technology. You can see some of the consoles and stuff that are associated with it, but he actually lived with the device for about 112 days, I think, before expiring. And then a really big leap is in 1988 where Dr. Bernhardt actually at the Boston Children's Hospital implanted a left ventricular assist, the first left ventricular assist device, durable device that's kind of more in line with our modern therapy in a pediatric patient. So first, we'll talk a little bit about percutaneous circulatory support. Intra-aortic balloon pumps, you all kind of know. We're not going to spend too much time on them. Abiomed, I listed it there to kind of, note that it's out there and it's an option, but it's really kind of fallen out of favor, especially with the rise of Impella and the tandem heart. So we'll kind of focus more on those. The tandem heart, this is a paracorporeal system. It has an external continuous flow centrifugal pump. So what you do is you run a catheter up the femoral artery, which is your outflow. And then for the inflow to bypass the left heart, there's a catheter that goes up and crosses the atrial septum. So you usually have to have the cardiologist involved with this. A lot of the interventionalists are very facile at crossing the septum for doing various procedures. And you'll actually place the cannula across the septum to the left atrium to bypass the left heart. So people can walk around with this and recover, and while you're waiting recovery with pretty good support, it can generate a lot of flow. The cannulas are pretty big, and that's probably the biggest drawback to it. And part of the reason I think Impella has become more popular is it's just less technically involved. You don't have to cross the septum and do that sort of thing. And there's, of course, complications that can be associated with that. But this is a very, very useful device that's been used with a lot of success in a lot of centers, and seems to offload the ventricle quite well. The Impella, I don't know if this video is going to work, but this is, we've talked about it here a lot in our conference. This is something we really use a lot and love. It's a truly minimally invasive ventricular support device. There's a little video here to kind of show how it works. This is a transfemoral device being placed, but essentially you run it up around the aorta and across the aortic valve, and it sucks in blood from the left ventricle and shoots it out in the aorta, so the ventricle doesn't have to do any work. The one they're showing here is an Impella 2.5, which is a transfemoral system, meaning 2.5 means it generates about 2.5 liters of flow, which isn't quite enough to meet the body's needs, but it can help support people, especially when their heart is doing some of the work. And then the CP device can do more flow than that, and that can also go transfemoral. This has become really widespread and used really well, or used in a lot of centers. 17,000 implants so far, and they're coming out with all sorts of variations of it. We've had a lot of success using the transaxillary approach, as in that patient I mentioned in the beginning. The reasons we like that is, first of all, we can place a 5.0 Impella, which means we can pretty much hopefully do all of the work for the ventricle. It does require, it's a bigger cannula and a bigger device, so it has to go in through a larger vessel. We like doing these PTFE grafts on the right axillary artery and then placing it across the aortic valve that way. Another advantage that we found with the axillary approach is that it doesn't move around so much. That's probably the biggest drawback to the transfemoral setup. Well, one, they can't walk, so if you're trying to rehab them, that's a challenge. But then secondly, that it tends to move a lot. Since this thing is running up a long way, it can shift, and it really has to be placed just right across the valve, or it's not going to flow correctly. So with the axillary setup, it really kind of holds it steady and can be quite durable. So this patient I have a picture of here, this was a 13-year-old girl who came in with viral myocarditis, was pretty sick, decompensating, and we put an Impella in her. She actually had it for 50 days, 50, and we waited for her ventricle to recover, and eventually as it recovered, she was able to have that removed and go home. So it's pretty useful device for the right patient. And then this one, this has really come out just in the last few months. We're not doing it here yet because they're kind of limiting the centers that have it available, but everybody's pretty excited about it. It's the Impella RP, which you can actually place up through the venous system to offload the right heart. So up until this point, we haven't had a lot of good options for acute right ventricular failure. Some people, even after an LVAD, might just need a bridge for a few days while the right heart recovers. So this is one of the first devices, percutaneous, that can be used to offload the right heart, and I think this is going to have a big impact. So I was hoping to kind of find some data on Impella and kind of where we are with it and the success people are having. And then I came across this, which I was really interested in. This is, it's still in press. It's online first type of thing, and it's actually guidelines that are coming out from the American College of Cardiology on the use of these percutaneous support devices. So as I mentioned, a lot of these have been kind of used off-label, so to speak, because they were never approved for this prolonged therapy, but people are using them. They're having a lot of success with them, and so now the field is kind of starting to look at it and say, hey, we need to make some consensus statements. We need to start really collecting data and seeing the utility of these things. So they did that. They got together, and this is coming out right now. And some of the consensus statements that came across with it is that a percutaneous support device, and they're really just talking about those two devices that I just mentioned. It's really just the tandem heart and Impella. Percutaneous support is better than IV inotropic therapy. Place it early so that you kind of avoid the downward spiral of worsening cardiac output and systemic hypoperfusion, all that thing. It's probably better than a balloon pump. So that's been something that's been kind of debated. I mean, how much better is it than a balloon pump? What are we gaining? People just don't really know. And so, we're trying to kind of show some of this with data now. And then it's also probably more cost effective than a balloon pump. Early analysis are showing that it's even though the device itself is a pretty high price tag, ultimately the hospital bill is going to be better for these patients compared to not only a balloon pump, but also in an emergent setting, ECMO or LVAD on preliminary analysis. So I think that's really important in terms of how these things get approved and reimbursement for it and all that sort of thing. And then, one thing Dr. Atkins has talked with me about before too is, we may get to a point someday where it's not right now we have the door to balloon time. So somebody comes to the ER with acute massive MI, centers are rated on how fast they get them to the cath lab and start doing PCI on them. Well, there may be a point sometime where it's not about getting them to a balloon or a stent, but maybe just offloading the ventricle. It could be a door to device time while you figure out what's really the best therapy for that person, rather than putting in a drug-eluting stent right away just to get them through their MI, and then all the things that go along with that, because maybe it's a better person for cabbage, maybe they need a different set of PCI. So that's just something that could happen in the future, and they're investigating that now. What's the role of this thing in acute MI with acute cardiogenic shock? So durable devices, there's a big list. I didn't even include the whole list because it's changed a lot over the years, but the ones that are listed in red are things that are currently being used in the US for various indications. The ones in black have kind of come off the market but were used in the past, and there's been mergers and changes in company and that sort of thing. The ones in blue are actually kind of in investigation right now and are coming out and will be coming soon. We'll kind of skip those. The ones in purple are all total artificial hearts. Just based on time, we didn't really have, I really couldn't go too much into total artificial heart. But the Syncardia system is really gaining a lot of traction right now. We'll talk a little bit about it. And then there's these other ones that are coming down the pipeline that people are pretty excited about. So the first real LVAD that hit the market and had a lot of, really sort of impacted the field and got things going was the HeartMate IP, which was the very first version that was quickly upgraded to XVE. The first implant was in 1991, and it gained FDA approval in 94 as a bridge to transplant. So these are patients that were waiting an organ but needed some support while they're waiting, and they could have this device placed. This is consistent with the modern era of these things. You have an inflow pump that goes in the apex here. It sucks all the blood off the ventricle, and then it pumps it out through this outflow graft to the aorta. Just real briefly, and these are the ones we place now with the HeartMate II, the newer version of it. But we essentially can do a lot of it off pump. We get in if they need other things done, like a valve procedure or even a bypass, which we've done recently, a coronary bypass. We can choose to do those things up front. But if they don't need that, they can stay off pump. We can sew the outflow graft on, create a big pump pocket because this needs some room to sit above the diaphragm, and get all that ready. Get a site ready for the driveline device. Then we go on pump. We core out this circle in the ventricle and place the inflow cannula, and then basically hook the device up and kind of wean off cardiopulmonary bypass and switch things over to being on the pump. So the Rematch Trial was a big deal for this device. It was started in the late 90s, and this was the first real trial that sort of showed that durable ventricular assist devices help people. So it was 129 patients, end-stage heart failure. They're randomized to either optimal medical therapy, which just meant IV anitropes, versus having the HeartMate XVE placed. And you can see the graph there. People survived a lot better with the LVAD. It wasn't great, but it was much better than medical therapy. So at 1 year, it was about 50%, and at 2 years, it was 23% versus 25% and 8% for optimal medical therapy. So it was better than double survival having the device placed at 1 and 2 years. So with that, the FDA approved it, and this was the first device that really came out, and things got going. Drawbacks with it, it was a good pump, but it was quite large, so not all patients qualified for it because you had to have a certain body habitus. And there were some problems with thromboembolism and driveline infection, which we still have now, but these were all things that they improved on with the next device. One thing to note of it, though, is this was its pump. It was a kind of a diaphragm pulsatile thing, so it was a diaphragm pump that gave pulsatile blood flow so those patients weren't anticoagulated. The HeartMate II was the next generation, and this is what we implant now. This is what we're doing at UC Davis, and this is the world's most popular left ventricular assist device and the most studied. And this is the big difference between the two is this is a continuous flow device. So there's actually an axillary rotor that pushes the bloodstream along. And these patients do require anticoagulation, for lots of reasons, which we'll talk about. But that was a big difference between the two. And then interestingly for this device is this was the first one and still the only one in the US that was approved for destination therapy. So they're moving away, or still including the bridge to transplant patients, but now it's actually for people that aren't going to get a transplant, but just want to have prolonged quality and quantity of life. So it received a destination therapy indication, which was a big deal, and that was in 2008. They studied their own two devices head-to-head. This was the pivotal trial between the two, and showed pretty clearly that there was better survival with the HeartMate II continuous flow device, and there was less pump thrombosis, less stroke, less infection, which was probably due to improvements in the driveline and better understanding of how that works, and so that really, it's gotten to the point now where the pulsatile generation 1 isn't really implanted at all. And you see the survival is good, but still with some challenges. The 1 year is about 70% here, and then going out to 2 years, it's about 60%. So some improvement over the XVE, but not as good as where we are now. We'll talk real briefly. These are the other ones that are kind of out there right now. The Jarvik 2000. This right now is only available in select centers in the U.S. as a bridge to transplant, but it's being currently evaluated as a destination therapy device. So that trial was started in 2012. They wanted to follow patients out for 2 years to see how they did. And that data, I think, is now being accumulated and analyzed, and they're really, I couldn't find anything on a real late update on where we are with it, but the hope is that this will be something that's approved for destination therapy in addition to bridge to transplant. Now, some of the things that are really interesting about the Jarvik 2000 is, one, it's very small, so you can see the HeartMate II is not all that big, but the Jarvik 2000 is even smaller, so that has implications especially for women and children and smaller people. And then one really novel thing they've done is the driveline for it, rather than exiting out through the abdomen, like you see on the HeartMate II, is actually tunneled up around and goes behind the ear. And the reason they did that is because like ear stimulation devices and other things that have been tunneled through there have shown very low infection rates, so they wanted to see how a pump line would work in that position. And so that's actually a subgroup analysis of the trial that's undergoing right now, is how much that post-auricular placement may affect infection rates and other things with this device. So I think it's a really forward-thinking, interesting development that might impact the other devices. And then another thing is the patient can actually regulate the speed adjustment. So if they know if they want to take a vigorous walk or do something active, they can actually change their flow a little bit, which is quite different than the other. So some interesting things with this device. The XCore, this isn't truly an intracorporeal LVAD like the other ones, but I think it's worth mentioning because it's really the only option we have right now for pediatrics. So kids with severe ventricular failure and even babies, this is an option now where there really just wasn't anything 15 years ago. And they did a good trial, pretty good trial, New England Journal of Medicine in 2007. It was a prospective, just observational trial in select centers where they implanted this device, and just to kind of see how the kids did relative to a historical control group with ECMO. And it did show quite an enormous improvement in patients that were able to survive to get to transplant. So there's two different arms here based on the patient's size. So kids that had a very small BSA were put in one arm, and normal BSA in the other, and that just kind of implies kids that had other things going on, or poor weight and poor growth and that sort of thing. But in both of the groups, there was a tremendous survival advantage versus ECMO, which was the only current existing therapy. A lot of the kids, actually in the kids that had a normal BSA, they exceeded the observation period on the median survival, so they don't know what the median survival was for that group. It was about 140 days for the kids that were on the smaller side versus 10 days for ECMO, so 14 times. And then there was a fair amount of adverse events noted, but 80 to 90% of the kids got transplanted versus about half of the kids on ECMO. So with that, it got an indication, and it's really only available in certain centers right now, but it's kind of the only real option we have for kids, and I think that's why it's worth noting. There's an adult version of this as well that's not used in the US, and there's actually a implantable device that's used in Europe for children. The HeartWare 2, this is one to pay attention to. Right now it has a bridge to transplant indication since 2012. In Europe, though, they're using it as destination therapy. You can see how small the device is, and that's probably its biggest thing, other than also having a centrifugal pump, which has some implications for flow and thrombosis and that sort of thing. But having that very small device size makes big implications for the ease of implant. The endurance trial is going on right now, where again they're looking at this for destination therapy. It's kind of similar to the Jarvik system, where it was started a few years ago, and the patients are being accrued, and they're currently being evaluated to see if this is going to happen. So probably in the next year or two, we're going to know whether these devices are going to be available for destination therapy. But a couple of things they're looking at here that are kind of interesting is there's a subgroup analysis where a lot of centers are placing this through a thoracotomy rather than a sternotomy. It's so small and so facile to work with that you can do it through the chest. And so they're actually looking at those patients as a subgroup to see if they have advantages over the sternotomy and all the things that go along with having a big incision. And then also they've done a lot of work on really tightly managing blood pressure control on these patients, because they think there's some advantage to that. So that's going to be important data for the field as well. So now a little bit about the data. I think this is a really interesting component of the whole field and what's going on with it. In 2006, the Intermax group kind of came together, and basically it's a national registry for all these devices. So you almost wish you had this for everything in surgery, right? Like a new stapler comes out, and everybody who's using it has to basically submit data to it, and it's all pooled, and every few years it gets looked at by a panel that's funded by the one of the U.S. Health Department groups, and it's really powerful stuff, for society and for the field. But they accumulate their data. And one thing that's important with the Intermax is they sort of stratify patients based on how sick they are and where they fall in that spectrum. So we have the 1 through 4 and A through D. Well, all these patients are basically class 4 or D, right? They're all end-stage heart failure, but it's 1 through 7, with 1 being the crash and burn, meaning somebody who's like actively dying. I mean, they're going downhill faster than you know what to do, and they just need to have something done or perish. And then you have these other people that are 2 and 3, which are kind of similar to transplant candidates 1A, where they're not doing well, they need inotropes, maybe even at home, and they're at a point where they really can't do anything because of their heart failure. And then 4 and 5 are more kind of like the 2, I would say, for a heart transplant patient, where they're on medical therapy and that's managing things, but they don't really have much quality of life and they're on a downward slope. And you can see some of the survival curves there. We've talked about that a little bit already, but once you kind of get into this classification, your survival is poor and you're moving in the wrong direction. So for the last 5 years, they recently published this data. This is a review of almost 10,000 patients nationwide who've had these devices placed over the last 5 years, from 2008 to 2013. And again, I wish, you wish you could have data like this for everything we do in medicine. But they looked at everybody and monitored their survival, and I think it's pretty good, especially compared to the first few trials. So the 12-month is 80%, and the 2-year is 70%. So that's nationwide with 10,000 implants. And these are pretty much all HeartMate II devices that have been in place. So we've made a lot of improvement really just in a short time period, and that's multifactorial, and we'll talk about that a little bit. But still there's some room to go. Implants from 2006 to 2013, this is to show that about 2,500 were done in 2013, the last year we have data, so that's equivalent number to the amount of transplants. So there's a lot of these things being placed now. And then interestingly, the number for destination therapy is rising quite dramatically, right? So these have traditionally been for bridge to transplantation, getting people ready to get a heart, but now we're seeing a huge proportion of these patients that this is what they're going to get. This is their therapy, not waiting for an organ. Over 1,000 of them in 2013, and I'm sure that number is just higher, not higher for 2014, and it's probably going to keep growing. If you look at the types of patients that are getting it, basically class 2 and 3 Intermax are mostly where the numbers are, 38 and 30%. So a few of them are the super sick people. Very few of them are the ones that are already class D or class 4, not doing well, but haven't had a device yet. So mostly 2 and 3. And interesting to note about their survival is that when you look at survival based on how sick they were when you implanted it, I think those graph curves are pretty tight, actually. So there's some difference, but not a huge difference between being a level 1 and a level 3 or 4 in terms of how you're going to perform over time. So I think that's in that way you have to look at, just because somebody's really sick at the moment doesn't mean they're necessarily going to do that much worse than somebody who's not quite as sick. And then another interesting thing with this is that patients that are quite a bit older tend to do worse, and I think that is a substantial difference. So the groups that are over 70 years old have much decreased survival relative to the relatively younger patients. Other things that contribute to people not doing well with this is kind of a lot of the stuff you'd expect: evidence of liver dysfunction, malnutrition, right heart failure. So if the right heart's not doing well, they need BIVAD therapy, or it's just a risk factor for not doing well. And then high body mass index, those sort of things. But in determining who exactly is too sick for the devices, I think honestly right now we don't know what should disqualify somebody from it or should qualify them for that. And that's what this slide is about. So Dr. Adamson was actually involved with this paper as well, but a scoring system was developed a few years back. It's actually called the Destination Therapy Risk Score. So they looked at a lot of those same factors based on historical data on outcomes and stuff like liver function and anemia and renal function, and developed this scoring system to kind of determine who is low, medium, and high risk for having a device implanted. And on this review of using that scoring system to stratify patients on over 1,000 people, they come to understand that it's really not very good at doing that. There's a poor discrimination when you apply it to bridge to transplant patients, so not exactly what the score was designed for, but it's still applied to it. And very modest discrimination for destination therapy patients. So what that is to say, and the reason I bring it up, is that I don't think we really know yet who should be disqualified for these things, who's too sick, who's not too sick. We just don't have a good mechanism right now for really stratifying people in an exact scientific way, which is true of a lot of things in medicine. A lot of it's sort of clinical assessment and a team-based approach, but it's an area that I think is definitely a room for improvement for the field. I don't think any talk about ventricular support would be complete without talking about this article from January 2014. This really kind of hit the field in a big way. There was all of a sudden a big uptick in pump thrombosis in a pretty short time period. So in 900 patients at 3 very busy centers, including Duke, WashU, and I think it was one of the Harvard, or it was Cleveland Clinic. They all of a sudden noticed a lot of pump thrombosis where there wasn't before. And these were early pump thrombosis, so meaning less than 3 months. So traditionally they were expecting that in about 2% of patients, and all of a sudden it was 8% of patients. And nobody was really quite sure why this was happening, but they raised the red flag and put this article out in the New England Journal of Medicine pretty quickly, and kind of said, hey, this is an issue. Something's going on right now. One thing that came of this, and looking at their data, is there was a real abrupt increase in LDH values right before confirmed pump thrombosis. So that was one thing that kind of helped with the monitoring of things. Looking at reasons for it, in their article, they noted some minor changes in the device production and stuff, and then looked at the surgeons implanting it. But there was no big changes in the device. It wasn't surgeon specific, so it wasn't like there was one center with one surgeon who's having a lot of these. It was kind of across the board. But one thing they noted is that they all kind of manage the anticoagulation a little bit differently. Again, these are mostly HeartMate II patients that need to be on warfarin. And there was really right now no standard way of managing that anticoagulation, because nobody knows what the exact right way to do it is. So they just kind of put this out there and left it. And I think the fallout from that is there hasn't been a defining resolution to the whole thing. And I think it's hard to know just yet with the data if that's gotten much better or worse. But I don't think it's really gotten too much worse is my sense of it. And a lot of people have kind of looked at the reasons why this may have been going on, and what could contribute to things. This is a good paper by, again, Dr. Adamson, and this is one thing he's talked to us a lot about, is really the placement of the pump. So you can just see the difference between A and B there, that might cause some disturbances in flow and altered trauma to the blood cells and hemolysis. So he really has been kind of pushing this agenda a little bit at how important it is to have the angles just right from the inflow and the outflow, and making the pocket very deep and sitting the device very low. This can be kind of challenging because a lot of these patients may change their body habitus after this. So as they become more physically fit and start doing more things, their habitus may change, which can cause some pump migration. So not much you can do about that. But up front, placing the pump in a very good way and securing it down deep, which Dr. Atkins has really implemented here. And then also just taking care on that outflow graph. So some of the technical things that might be contributing to this. It's a really good paper by Dr. Blitz. I think he's a really interesting surgeon. I haven't met him personally, but he puts out videos all the time on our main website talking about all the things he does. And he wrote a really good review on some of these issues associated with pump thrombosis and kind of classified it to different things. So one thing is that the pumps themselves. So they were able to do some pretty sophisticated engineering type studies to look at flow dynamics, and kind of like they do with an airplane or a wind tunnel or something like that, just kind of see if there's maybe areas of stasis we weren't recognizing before. And sure enough, they found that a lot of these pumps did have areas of probably flow stasis that just weren't recognized initially when they were being developed. And some of it has to do with the components of the device itself. So on the heart wear device, they noted that certain portions of the outflow cannula, if they had one type of titanium versus another, were related to differences in thrombosis. So I think that's kind of an interesting way of looking at it, some of the engineering components to it. Patient-related factors, again, hypertension is becoming more and more recognized as a risk factor for not doing well. It puts increased strain on the pump because of afterload increases, and then also the positioning, which Dr. Adamson talks a lot about. And then how we manage these patients post-op. Right now, there's no standardized way for anticoagulation. Nobody knows what the exact right answer is, which meds they should be on. But a lot of centers were getting pretty liberal with it. They were, I think, even they noted in the New England Journal article that a lot of centers had kind of relaxed their anticoagulation protocols because they weren't seeing a lot of thrombosis, and they just kind of backed off on the INR goals. A lot of patients also stopped getting antiplatelet therapy. And then what this little diagram here shows is there's a lot of reasons to also increase thrombosis for other reasons. A lot of these patients have problems with gastrointestinal bleeding. This pathophysiology is very similar to Heide syndrome, which sometimes shows up on abscites and stuff like that. But there's an association between aortic stenosis and arteriovenous malformations, classically in the right colon or ileocolic area. And so patients that, and what that really has to do with is the red blood cells that cross the aortic valve through a stenotic valve get beat up, and the von Willebrand factor, there's a relative deficiency of some of the elements, which then results in a coagulopathy that's kind of hard to characterize with standard lab values. And then for some reason that people honestly don't understand as of yet, they also tend to form arteriovenous malformations. Well, that pathophysiology is totally applicable to LVADs as well. The pump, the rotor pump, beats up the von Willebrand factor. They all have the von Willebrand deficiency. They tend to get arteriovenous malformations. So you have this combination of a relative coagulopathy and AVMs, which results in bleeding. So when people are bleeding, the tendency is to get rid of the antiplatelets, get rid of the warfarin, and that was probably contributing to some of this pump thrombosis and continues to. And then also aortic insufficiency and afterload and lots of various things. So I think the important thing here is that people are really looking at it quite carefully and why these things may have been happening and what we can do about them and all the elements that go into it. Why do these people ultimately die? Well, those are the big things: infection, bleeding, right heart failure, neurologic events, device malfunction, and multi-system failure. What are we doing about them? Well, I think with the bleeding, the surgical approach, just meticulous hemostasis, these can be quite challenging. It's not unusual for the patients to be totally dry at the completion of the procedure and then start having some bleeding and stuff as the von Willebrand deficiency kicks in. Really watching the INR, so very aggressive Coumadin clinic type of stuff, and then changes in the pump design. Right ventricular failure, I think, again, people that do a lot of these devices and have think about it and trained in it really, have a very good awareness of the right heart and what it's doing and if that's going to be a problem or not be a problem. There's a very liberal use of inhaled nitric oxide, which I think is probably crucial for having these devices placed. It really offloads the right heart while not affecting the systemic blood pressure. So that's something we use quite liberally for these patients. Neurologic, same thing. In terms of the bleeding, which is really careful INR managing. The hypertension has become a bigger awareness of that. And then also pump design, and we'll talk a little bit about the newer generations and what they're doing with that. And then infection, probably the biggest problem with infection is these drive lines. They come out, I say the abdomen, but really they should kind of become extraperitoneal and come out through the wound. We saw a patient a couple weeks ago in the hospital who had a device placed in 2006, I think, at a different hospital. And the drive line was really long, and some of the cuff that's associated with it was actually outside of the skin, which we don't do anymore. So I think in the early days, before the drive line infection was recognized to be quite as much of a problem, there was not as much awareness on meticulous care of placing it a certain way, and then also caring for it afterwards, which is a big deal here with our drive line care. Patient selection, again, I think that's a big challenge for the field, but trying to be more choosy about who's going to get a device will probably ultimately help results and overall survival. And then design improvements are going to be a big thing for malfunction. And just one quick thing with this, I think a really important component of these devices is that they're quite expensive. This is a big investment for institutions and insurance companies and all this sort of stuff. And so that really the finances of it have to be somewhat scrutinized. And right now, the data is not perfect, but I thought this was a very interesting paper, kind of looking at sort of the cost associated with different modalities on a very much statistical model type of analysis. But what they found here and what they sort of concluded on their model was that for patients that you don't do anything for, meaning a heart transplant or a device, so they're just managed on optimal medical therapy, which is usually IV inotropes, they're probably going to live a very short time period, on average less than a year, and it's going to cost the system about $100,000. Well, if they get a heart transplant, an early heart transplant, they're on average going to get 8.5 quality-adjusted life years. So their survival will be probably a few years longer than that, maybe on somewhere between 10 to 13, but quality-adjusted years, meaning good, functional, living survival, they're going to get about 8.5 years on average at a cost of about $100,000 extra per year, which is $100,000 is a number that I guess a lot of people that analyze these sort of things look at as being sort of an economically feasible number for keeping somebody alive for another year. So that's the most efficient and probably the most durable option for these people. Now for what we're talking about today, people that get an LVAD as a bridge to transplant, going to get a heart. Those that are transplanted will have a much more expensive overall course. They're going to live quite a bit longer. Quality adjusted life years 12, so even more than just an upfront transplant. I think that's because probably they have the LVAD for average of 3 or 4 years, and then they get the heart transplant, so they get another 8. But it's going to be about twice as expensive per year on average. So that's a little bit above the economic feasibility that cutoff that most people would use. And then for people that are just destination therapy, it's pretty similar. The survival's not as good. They're going to be about 4.5 years of quality adjusted life years. They'll probably live a little bit longer than that. But it's about $202,000. So again, still not economically feasible. So I think it's an interesting, and it's going to become important in this debate because you have all these old people and heart failure, and when they should get a device and how are we going to fund all this thing. But so it's good that people are looking at it and kind of trying to put some real numbers on it. And then lastly, with the data side of things, these people really, they tend to do better. This is from that same Intermax data, 10,000 patients. And when you talk about quality of life, patients on a visual analog scale, so meaning just how good is your life compared to before, you can see on the left graph, there's a big increase, 30 to 40% versus 70+% on just an overall quality of life. Probably what's important to a lot of patients, being able to do self-care and usual activities. Usual activities before device placement, 90% problems, a majority of those are severe problems. And then after they get the device placed, they can do a lot of usual activities that they couldn't before. So they feel better and they're able to do more things and have some more time that's worth it for them. A couple of trials coming down the pike that are really going to be important for the field is the Roadmap. It's an observational trial where they're comparing patients that are Intermax 4 to 6. So you saw the data on 10,000 patients. Most of these are level 2 or 3. They're looking at patients that are 4 to 6 versus optimal medical therapy. So if a big increase in survival and quality of life is shown for those patients that aren't quite as sick but still pretty sick, that could have big implications for indications and aggressiveness in placing these things. And then an even more aggressive indication of that is the Revive It trial, where they're actually looking at NYHA 3 patients, so patients that aren't even quite end stage and wouldn't necessarily be listed for a transplant, versus optimal medical therapy with an LVAD. So this is a big deal. If these things come through and the data is really convincing, I think there's going to be a lot more interest in placing these in a lot of patients from the heart failure world. A couple of the new devices that are exciting, the MVAD, this is the microventricular assist device. It's the next generation from the HVAD. Again, a centrifugal pump, but look how small that thing is. And this is, again, the device that was being placed through thoracotomies. Pretty minimally invasive, big implications for children and small people. And then another really interesting thing about it, a lot of the companies are working on this, but they actually have a system for it that's pretty well progressed, is this transcutaneous energy transfer. That's what the picture on the bottom left is showing. So not having a drive line at all. Again, that's the big problem for infection. So this would be like a cell phone thing that you can put on one of those little pads that'll charge your phone. You can just put your battery up against your skin and charge this thing up. The HeartMate III, this has actually already been implanted in Germany, and it's under trial there now. This is the next generation of, again, the world's most used and popular LVAD. A centrifugal pump, so the other was the axial rotor. And both this, and I mentioned the MVAD, are actually a magnetically levitated rotor. So what it means is there's no bearing, and the parts aren't in contact with one another. So this is really important for hemolysis and trauma to the bloodstream. It's the engineering is such that the rotor is freestanding and it just spins the blood through. Things they're trying to do with this is it's a very small drive line, so that's one helpful thing, but they're also working on a transcutaneous energy source. The controller for it's going to be very small. They call it the pocket controller, something you just slip in your pocket and walk around with. So pretty minimally invasive. People can work and stuff like that. And they are now with the current devices, but even less cumbersome. And this is actually it's in trial now. The first implant was in June of last year, and it's going to be under trial for destination therapy and bridge to transplant here. So hopefully we see that in the next few years. Didn't have time to talk about total artificial heart, but this is an interesting component of the field. 70 cc and 50 cc pump. They both just got recently approved for some interesting trials. In March of this year, they're approving the Syncardia total artificial heart for trial looking at destination therapy. So these have been traditionally used as a bridge to transplant for people that have biventricular dysfunction. You actually remove the entire native heart and implant this thing. 500 implants in the last 3 years, so this is becoming more and more popular. They're doing a lot of these at Cedars-Sinai right now. There's a few other centers out there, but it's still kind of limited to certain centers, but now they're looking at it for destination therapy. So this is going to have big implications, especially as those that would only be able to get transplant before. And then the smaller pump, the 50 cc, just also recently got approved for trial to look at. And it's being put in 3 different arms, actually: children, women, and compassionate use. So these are a lot of the patients that traditionally weren't candidates for this Incardia total artificial heart because the device was just too big for them, and now they have an option. This is one other one, the Carpentier total artificial heart out of France. Dr. Carpentier is one of the fathers of mitral valve surgery. He's been working on a pump that has all biological surfaces, even uses, these valves are very similar to the ones we put in almost every day around here for aortic valve disease and that sort of thing. But it's pretty much trying to create a biologic paradigm so you don't have to have any anticoagulation and minimize tissue trauma. So right now, things that are going on is this: I think the non-contact levitating pump is very interesting and probably will improve the damage to the bloodstream and the overall function of things. The centrifugal pump design is looking to be probably a superior method. Transcutaneous energy systems, it's obviously patients are going to like that. Very small devices, minimal invasive implantation. And then soon, I think things that we can look forward to, and there's data on and basic science studies going on right now, is one thing is reverse ventricular modeling. So there's some interest in trying to regenerate the heart with matrix or stem cell implants in patients that have a device in place, and rather than just only looking at transplant or only leaving them to destination therapy, actually doing something proactive to try and get their native heart to recover and eventually get explanted. And then the biocompatible surfaces, as mentioned in the Carpentier heart, where you have a better biological interface and a more natural tunnel for the blood to move through. I think moving forward, we're going to see increased utilization of destination therapy. You saw that it's becoming more and more utilized every year. But you also get the sense that there may be some more regulation on who's able to do this. So right now it's been kind of an open thing. If you want to do it and you want to start a program and your hospital's invested in it and has the financial resources, you can start a program. But with all the implications of everything and the risk and the cost, there may be some interest in really regulating the centers that are able to do this. So it's probably good to get in on it on the ground floor and start now if you want to be involved with it. Wider indications for implantation. Those studies I mentioned have potential to really rattle the ground on how what type of patients can have these and how aggressive we are in putting them in. There's been I've heard some talk too about the UNOS designation. Right now those 1A patients are people that are in the hospital, crashing, dying, but there's been some talk of increasing the patients that have a device in place as having a higher status than the patients that are at home on IV inotropes. So right now, if you're at home on IV inotropes or have a VAD, you're 1B. But that may change to where having a device actually gets you a higher chance of getting a transplant than being at home on IV inotropes. And the reason for that is because they're seeing that patients that have a VAD in place survive better, get to transplant better, do better. So they're kind of probably want to encourage that sort of therapy rather than sitting at home with a drip. So that could have really important implications for the people that are getting referred for devices. And then eventually they may get good enough that transplant becomes less desirable. So a little bit about our program here and what we've kind of been doing the last few years with it. So our first implant was in May of 2011. The longest patient is 3 years and 11 months out, so that's pretty good. Total number of implants are 16, but we've done 8 of these in the last 6 months, so Dr. Atkins has been keeping us very busy. And 14 of them were unique patients, 2 of them were pump exchanges, 13 men. We recently did our first woman earlier this year, with a wide range of ages. Etiology is kind of, there's a variance there, but a lot of them are non-ischemic patients, some of them are ischemic. We did reduced sternotomy in 5 of them, and so that makes things more challenging. A lot of them had other things done too as well, valve repair, one person had a coronary bypass, things like that. Some of them have moved on. One person was able to be transplanted, one is being currently listed, the patient I talked about earlier. One withdrew and one died. These are our spectrum, kind of consistent with national data. Most of them are class 2 and 3, but a couple people on 1 and 4. And then I think our survival is something to be happy about. At 6 months we have 100% survival, so that's pretty good. It says a lot about our team and what we're doing for these people and patient selection and the whole gamut of stuff. At 12 months we're at 86%, which is again 80% nationally, so we're a little bit above the average there on our small series. At 2 years we're at 80%, which is well above the national average of 69%. And a lot of these patients, they just haven't been followed out far enough yet to know where we're going to go with this. So it's a real testament to our heart failure team. Freedom from driveline infection at 3 months is 100%. Again, really good line care. And then how people are feeling, over 70% of patients have had an improvement of at least 2 classes of heart failure symptoms, meaning from 4 to 2 at 3 months. So they're feeling a lot better and doing a lot better. And the other 3 outliers are at class 3 right now. So nobody's with debilitating heart failure symptoms. And they're feeling a lot better. This patient here, he was the first UC Davis implant. He's also the tallest patient. And he sparked a bomb threat once when he went to the airport with all of his batteries in place. So he's notable for both of those things. This patient here, he was implanted in July 2013, and I wasn't part of this at the time, but I was told that his main goal in wanting to survive longer was to make it to his wedding anniversary, which was a few months later in 2013. Well, he recently just had his 50th wedding anniversary over a year later because of the device that was placed for him. And he's also notable because he was the first patient to have a non-cardiac sort of a general surgery procedure performed while he had the device in place and he had a hernia repair. This woman is our first female VAD patient. This was a postpartum myocarditis, cardiomyopathy, I should say, just complete ventricular failure immediately after giving birth with a newborn baby. So she's surviving and getting to raise her child, and she gets the award for the cutest baby. And that's the one on the right, not the one on the left. But so we're very, very happy for her and that she's getting a chance to be with her child. And this is a picture that was taken last winter during the Christmas party. All these, again, it's kind of a small group of patients, and they're all, very much followed by and closely taken care of by our heart failure team. So it's kind of a close-knit group, and they had a Christmas party here in the hospital that a bunch of people went to. So in summary, I'd say that heart failure is a big national epidemic, and it's associated with very severe quality of life and survival. Transplant is obviously the best thing that can be done, but you've seen the data, and it's restricted, and there's only so many organs, and it's not the complete solution right now. There's a lot of options for mechanical support. We talked about that. I mean, I think the percutaneous stuff is really interesting too, because it's just getting smaller and smaller and better, and then the durable devices, the same thing. There's really been this focus on trying to stratify what's the best thing for a particular person. Even this whole bridge to decision sort of way of thinking about things. Just keep them alive for a little while until you can figure out what's going to be the best therapy for that person. There's a lot of devices in place. They're well proven. They're improving survival. They're still fraught with a lot of complications, and they're costly. And this is things that are actively being worked on, and I think we'll continue to see improvement. Again, we're at the very early stages of this whole field. A lot of exciting technology and development. We have a really good program here, and we have a lot of growth potential. Again, half our implants in the last 6 months, and so we've got a lot of room to grow here. And then just in general, especially for the residents, I think this whole field is very much in its infancy right now. We're at the very early stages of it. There's current trials going on as we speak, looking at putting these things for different indications, and really the approvals have all been within the last 15 to 20 years. So we're just at the very, very early stages of this, and it's going to be a big part of healthcare. It's going to impact a lot of different fields, and so it's worth paying attention to. That's my talk.
Oh, really outstanding. And as always, it's clear and understandable, and it makes me think I want a new heart because I, run faster, jump higher.
Yes, sir.
Ditto. Inspiring talk, really neat. Can you talk with us about what happens to the heart tissue over time as it's exposed, now to a continuous flow device? We've heard in the context of atrial fib discussions about actually pretty fast atrial remodeling. Mm-hmm. You briefly mentioned ventricular remodeling. What's happening to the heart, and is that going to impact on development of some of your other potential long-term strategies, pepper pot revascularization of the heart with stem cell treatment and things like that?
Yeah, and that's a good question. Hopefully it recovers. That's the ideal, natural history of that situation. So having a device in place and offloading it, basically letting the ventricle not do any work. Most of these are going to be dilated and relatively ischemic for a long time or whatever. And so hopefully by offloading it, you give it time to regenerate and regrow. And there is, a substantial proportion or, group of patients out there that have been explanted successfully. So they have a durable device in place for a given amount of time. They're monitored by serial echoes. Things progress, and then eventually they can just have the device taken off and live. That's kind of the goal with a lot of the percutaneous devices, is just give them some short amount of time for a more acute process. But other than that, I guess I'm not entirely sure exactly what happens to the heart in these patients. That the average patient who lives with 4 to 5 years for it on destination therapy. Again, the big thing is protecting the right heart and making sure that you're adjusting the flow and the volume just right, so that the right heart is functioning perfectly. If you suck too much, it'll bow the septum, which will cause right heart dysfunction and all of that. But I guess the ideal situation is that the ventricle has time to recover and regrow and take over the job. But I think in majority of patients that doesn't happen quite yet.
Getting the tissue to study is a big deal. I mean,
yeah.
Probably the heart that's removed during a transplant is your most interesting tissue.
Yeah.
The heart that's sort of, in a perfect dies, the autopsy heart may not be as interesting.
Well, and there are animal models as well. I think, this is just, we could talk about this all day. It's really exciting, and it really is a testament to innovation. And a lot of this has been driven by surgeons, because particularly this kind of field is what we can do, what we can bring. And so it really, it's going to be a great year to talk about innovation. We look forward to having Tom Crummell out. I know our guys are trying to do this with kidneys. It's not quite the same. We don't have the total artificial kidney yet, but this is a great time for the intersection of engineering, bioengineering, cardiac physiology, surgeons. It's just an exciting time to be making contributions. And thank you for your fabulous contribution over the last 2 years.
Yeah. Thank you.
Really a great contribution.